Thank you, Lena. Good morning, everyone. We're happy to provide an update on recent progress against our core priorities for this year and a view forward toward key upcoming catalysts. At Intellia, we're committed to developing curative genome editing treatments to transform the lives of individuals with severe diseases, and we're proud to be at the forefront of genomic medicine. Our deep scientific, technical, and clinical development expertise and robust intellectual property portfolio position us to transform the broad therapeutic potential of CRISPR-Cas9 into new classes of revolutionary medicines. Our leading platform supports a full-spectrum strategy which deploys differentiated modular solutions across in vivo and ex vivo therapeutic applications. For genetic disease, we utilize our in vivo approach, leveraging a lipid nanoparticle-based delivery system to selectively knock out disease-causing genes or precisely insert genes to produce normal proteins. Our ex vivo T-cell receptor, or TCR-based approach, is designed to produce a homogeneous, robust cell product that epitomizes a patient's own natural immune system to eliminate cancer cells. Across these efforts, we have generated a broad pipeline, including emerging clinical candidates and an expansive research stage portfolio following a rapid and reproducible development path. The first quarter was a productive one for Intellia as we continue to make headway across these efforts. We were pleased to receive the European Union's orphan drug designation for NTLA-2001, demonstrating regulators' appreciation of the potential significant benefit of NTLA-2001 in the treatment of ATTR patients for whom there is no cure. Additionally, we presented key preclinical data expanding our modular capabilities in new directions. In March, we introduced our proprietary base editing technology for enhanced cell engineering. In a separate presentation, we showed proof of concept for systemic in vivo editing in bone marrow. Platform innovations such as these lay an important foundation for Intellia's continued pipeline growth and the advancement of the next wave of genomic medicines. Finally, we were pleased to welcome Dr. Georgia Cressy, who joins our board with more than 35 years of pharmaceutical industry experience, including as a scientific and operational leader across stages of clinical development and commercial manufacturing. Our progress on these first quarter and upcoming milestones provides us the opportunity to advance not only our core priorities for 2021, but our long-term vision for Intellia. We continue the evaluation of the clinical profile of NTLA-2001, both as a potentially curative treatment option for ATTR patients and as validation of our non-viral in vivo delivery platform. In the middle of this year, we anticipate reporting our first clinical data with an interim look at our phase 1 study of NTLA-2001, the first systemically delivered CRISPR-based therapy dosed in patients. In addition, we plan to submit 2 first-in-human regulatory filings to advance our lead engineered TCR T-cell therapy, NTLA-5001 for AML, and our second in vivo knockout candidate, NTLA-2002 for HAE. And we remain on track to nominate at least 1 new development candidate from our research efforts by the end of the year. With key catalysts upcoming and a strong financial foundation, we are positioned to invest the resources and energy necessary to advance our pipeline, expand our platform capabilities, and deliver on our mission for patients. With that introduction, I'll hand the call over to our Chief Medical Officer, David Lebwohl, who will provide an update on our progress in the clinic with NTLA-2001. David?
Thanks, John, and good morning, everyone. I'll start with a bit of background on ATTR and on NTLA-2001. Transthyretin amyloidosis, or ATTR, is a rare, progressive, and fatal disease caused by the buildup of TTR protein in multiple organs. People living with the disease can have either the hereditary or wild-type form of ATTR, which results in a diverse range of disease manifestations, the most frequent being polyneuropathy and cardiomyopathy. Globally, there are an estimated 50,000 people with hereditary ATTR and between 200,000 and 500,000 with wild-type ATTR. Intellia's candidate 2001 applies our in vivo lipid nanoparticle delivery technology to knock out the TTR gene in the liver, which is the source of circulating wild-type and mutant TTR protein. therefore reducing amyloid deposition. Based on our robust preclinical data, which shows long-lasting TTR reduction of greater than 95% in non-human primates after a single dose, we believe 2001 offers the possibility of halting and reversing all forms of the disease with potent lifelong reduction of serum TTR following a single dose. In March, the European Commission granted orphan drug designation to 2001. As a reminder, this designation provides regulatory, financial, and commercial incentives to develop therapies for rare diseases defined as having a prevalence of less than 5 in 10,000 people in the European Union. This is meaningful as it not only reflects 2001's potential to deliver significant benefit over existing treatments for ATTR, but also the unmet need that remains in this population. We view this as an important acknowledgement that regulators recognize the benefits of a potential single-dose treatment in indications like ATTR, even when chronic therapies exist in the market. Importantly, this is in line with our conviction in this program, as well as feedback from leading investigators who are enthusiastic about the value 2001 would offer patients and our healthcare system. As you may recall, our first-in-human trial is an open-label, multi-center, two-part study evaluating 2001 in adults with a hereditary form of ATTR and peripheral nerve damage. The study will enroll up to 38 patients and consist of a single ascending dose phase in Part 1, and following the identification of an optimal dose, a single-dose expansion cohort in Part 2. The trial's primary objectives are to assess the safety, tolerability, pharmacokinetics, and pharmacodynamics of 2001, which will include the measurement of serum TTR levels following a single intravenous infusion. The secondary objectives are to evaluate the efficacy of 2001 on clinical measures of neurologic function in httr-PN patients. Once we have established the safety and the optimal dose, our goal is to expand the study and rapidly move to pivotal studies in which we aim to enroll both polyneuropathy and cardiomyopathy patients. By way of clinical update, we continue to enroll patients across global sites and expect to share interim results from the ongoing single ascending dose portion of the study at a scientific or medical meeting in mid-2021. These results will offer a preliminary view of the safety and activity profile of 2001 as we progress towards identifying the optimal biological dose. We believe our interim results will establish clinical proof of concept for a modular LNP delivery platform, an important milestone for Intellia, while demonstrating to the field at large the potential for systemic in vivo genome editing in treating life-threatening diseases. We're excited to learn how our ability to edit in vivo translates from our observations preclinically into humans, and look forward to sharing interim results mid this year. And with that, I'll turn this over to our Chief Scientific Officer, Laura Settler-Zito, for updates on our two additional development candidates, 2002 and 5001, and across our R&D efforts.
Thanks, David. I'll begin with our second in vivo knockout candidate, Intellia-2002, in development for the treatment of hereditary angioedema, or HAE. HAE patients experience recurring, unpredictable, and painful attacks of swelling across multiple tissues. Where there are approved acute and prophylactic therapies for HAE, the treatment burden on patients remains significant. We believe there is additional opportunity for a therapy that not only further reduces frequency and intensity of attacks, but which may prevent and eliminate them altogether. To that end, we're applying our modular LNP delivery system to Intellia-2002 to knock out the KLKB1 gene in the liver to permanently reduce plasma kallikrein protein and activity. This approach is expected to provide continuous suppression of kallikrein activity and eliminate the significant treatment burden associated with currently available therapies for HAE patients. In March, we presented preclinical results at the American Academy of Allergy, Asthma, and Immunology annual meeting demonstrating NTLA-2002 achieved greater reductions in serum kallikrein protein levels and activity as compared to published results of the current standard of care for HAE. These reductions of up to approximately 90% were sustained for over 17 months following a single dose in an ongoing non-human primate study of our xeno-specific NMP formulation for NTLA-2002. In addition, we presented data from a humanized KL81 mouse model of bradykinin-mediated vascular permeability, establishing that a single administration of NTLA-2002 prevented captopril-induced vascular leakage and therefore is expected to prevent HAE attacks. We continue to make steady progress with IND-enabling activities, and we expect to submit an IND or equivalent application for NTLA-2002 in the second half of this year. We're leveraging insights from NTLA-2001 and therefore anticipate being able to start NTLA-2002 at a higher dose for our first in-human study, which will evaluate safety, tolerability, and measures of activity, including levels of kallikrein knockdown. I will now turn to our ex vivo efforts. Here, we're using CRISPR-Cas9 as a tool to create engineered cell therapies. Similar to our efforts in vivo, our proprietary approach to cell engineering underpins a modular platform with versatility to mix and match cell types, targeting modality, and ability to introduce the edits necessary for eliciting the desired pharmacology. Regardless of solution, we're achieving highly efficient sequential editing with high yield, optimal cell performance, and scalable manufacturing. Our lead program, NTLA-5001, is a potential best-in-class engineered T-cell therapy designed to treat all genetic subtypes of AML. This investigational candidate is an autologous T-cell receptor, or TCR, T-cell therapy targeting the Wilms tumor 1 antigen. NTLA-5001 utilizes our proprietary cell engineering process, which is able to precisely edit and replace patients' T-cell receptors with a tumor-targeting TCR. This process reduces safety risks and should translate to improved potency and function versus other technologies for multiplex editing. Despite recent therapeutic advances delivering improved response rates in subsets of AML, long-term outcomes continue to be poor, with overall 5-year survival below 30%. WT1 is overexpressed in over 90% of AML patients, regardless of subtype. And so, between our proprietary cell engineering process and the prevalence of this target, we believe NTLA-5001 will be a well-tolerated solution capable of improving long-term outcomes for patients across all mutational subtypes and forms of AML. We remain on track to submit an IND or equivalent regulatory application for NTLA-5001 mid-year. Our first in-human trial will evaluate the safety and activity of NTLA-5001 in patients with persistent or recurrent AML who have previously received first-line therapy. Moving on now to our research programs and platform advancements, we continue to make strides in developing new therapeutic candidates for genetic diseases and next-generation engineered cell therapies for cancer. The versatility of our approach allows us to move quickly with pipeline expansion, and we remain on track to nominate at least one new development candidate this year. During the first quarter, we had oral presentations at 2 different scientific conferences, broadening the applications of our modular toolbox. In March, we presented preclinical data introducing our proprietary cytosine deaminase-based editing technology at the Cold Spring Harbor Laboratory Scientific Meeting on Nucleic Acid Therapies. The data highlights our expansive cell engineering capabilities that enable us to introduce multiple edits via CRISPR as required by next-generation allogeneic cell therapies. Additionally, at the recent Houston Genome Editing Meeting, we presented preclinical data extending the modularity of our in vivo delivery strategy. Through our extensive LNP discovery and development efforts, we identified a class of LNPs that achieve dose-dependent, therapeutically meaningful editing of bone marrow and hematopoietic stem cells in a preclinical mouse model lasting 1 year following a single dose. For inherited blood disorders such as sickle cell disease, this approach could greatly reduce the barriers to treatment associated with bone marrow transplantation. More broadly, these results demonstrate the ability to deliver to and edit tissues outside the liver. We will continue to expand upon this work with financial support provided by the Bill and Melinda Gates Foundation. Although still in the research stage, the technologies shared in this presentation are important demonstrations of our emerging capabilities, which together reflect our commitment to drive our pipeline forward through continued platform innovation to create potentially curative therapies for patients. Looking ahead, we plan to share preclinical data at the ASGCT annual meeting taking place next week. This will include an update on our research in alpha-1 antitrypsin deficiency, which is the second disease indication for which we have demonstrated robust proof of concept of our targeted in vivo insertion technology to restore normal levels of proteins in non-human primates. Further, we will be sharing data on our industrialized screening platform utilized to de-risk and identify viral RNAs that are both potent and highly specific with no detectable off-target edits. This foundational work has provided us and regulators with key insights and the confidence to move our programs, including Intellia 2001, forward into human clinical trials. We look forward to these presentations next week at ASGCT. With that, I would like to hand over the call to our CFO, Glenn Goddard, who will provide an overview of our first quarter financial results.
Thank you, Laura, and good morning, everyone. Intellia remains in a strong financial position as we advance our pipeline. Our cash equivalents, and marketable securities were $600.8 million as of March 31st, 2021, compared to $597.4 million as of December 31st, 2020. The increase was mainly driven by $45.3 million of proceeds from the company's at-the-market agreement, $13.3 million in proceeds from employee-based stock plans, and $2.4 million from the Regeneron collaboration. These increases were offset in part by cash used to fund operations of approximately $57.6 million. Our collaboration revenue decreased by $6.5 million to $6.4 million during the first quarter of 2021, compared to $12.9 million during the first quarter of 2020. The decrease was driven by the $5 million milestone payment earned from Novartis for the IND submission of OTQ-923 in 2020. R&D expenses increased by $4.6 million to $39.3 million during the first quarter of 2021, compared to $34.7 million during the first quarter of 2020. This increase was mainly driven by the advancement of our lead programs, research personnel to support these programs, and the expansion of our development organization. G&A expenses increased by $2.3 million to $13.6 million during the first quarter of 2021, compared to $11.3 million during the first quarter of 2020. This increase was related to employee-related expenses, including stock-based compensation of $0.9 million. Finally, we expect our current cash balance to fund operating plans through at least the next 24 months. And now I will turn the call back over to John for closing remarks.
Thank you, Glenn. As you can see, there are many reasons for excitement for what the remainder of the year holds for our company and the field of genomic medicines. Our phase 1 study of NTLA-2001 is progressing well, and we look forward to sharing interim results mid this year for clinical validation of our platform. We continue to progress our pipeline and expect to file a first-in-human regulatory submission mid-year for NTLA-5001. In addition, we expect to submit an IND or IND equivalent application for NTLA-2002 in the second half of this year. We're advancing our research stage portfolio as we expect to nominate at least one new development candidate this year, and we continue to expand our toolbox to enable the next wave of genomic medicines. With all this progress, and as we close in on key milestones, we remain focused on our core priorities and wholly committed to making genome editing's promise a reality for patients. We'll now open the line to any questions. Operator?
Thank you. We will now begin the question and answer session. To ask a question, you may press star then 1 on your telephone keypad. If you're using a speakerphone, please pick up your handset before pressing the keys. To withdraw your question, please press star then 2. At this time, we'll pause momentarily to assemble our roster. The first question today comes from Salveen Richter with Goldman Sachs. Please go ahead.
Hi, thank you so much for taking our question. This is Sonia on for Salveen. We have a few questions on Intellia 2001. So first is, what data should we expect from the read in mid-21? How many cohorts should we expect data from? And then the second question is, what is the status of the IND for Intellia 2001 in the U.S.? Thank you.
Sonia, thanks for the question. First of all, just to remind you, 2001 is a study that we're currently studying 2001 outside the United States. So for this first-in-human study, there's no plan to have an IND as part of this particular study. The expectation is that for subsequent work, we would come back to the U.S. and have an IND for work that would involve cardiomyopathy and subsequent studies. With respect to the ongoing study and the data we anticipate presenting, we're not talking about the number of cohorts, other than to say that we've progressed well with the study as it was laid out. And we're adhering to the principles that we'll have substantive data that's readily interpretable, and we look forward to sharing that.
Thank you.
Thank you.
Your next question comes from Maury Raycroft with Jefferies. Please go ahead.
Hi, good morning, and congrats on the progress. Just had a question on the 2001 clinical study. Just wondering if there's anything additional you can say on safety so far in the clinical study. I guess one concern in the past is on immunogenicity, and is there anything you can say about that at this point, and will that be part of the mid-year update?
Thanks, Maury. With respect to safety, I think it's best to look forward to the information that we anticipate sharing here mid this year. The study is progressing, and we're excited with the progress that we've made, and I think we'll address many of your questions at that point in time.
Got it. Okay. And then we've been getting questions too on LNP design and I guess some of the characteristics that go into your LNPs. And I'm wondering if we could learn more about that in the mid-year update and how your LNPs, the functionalization translates to an improvement in immunogenicity and also the tunable tropism as well.
thanks. As the year unfolds, I'm sure there's going to be opportunities to talk more about the platform and the work that we're doing. I think with respect to the clinical data that we're talking about, I would anticipate that most of the discussion at that time would be about the study and the results that we have. But as you know, Maury, as our science progresses, there's points in time where we'd like to share some of the advantages that we have, and there may be opportunities later this year to do that.
Makes sense. Okay, thank you for taking my question.
Sure.
Thank you. Your next question comes from Gina Wang with Barclays. Please go ahead.
Hi, this is Sheldon for Gina. Thanks for taking our question. So I think you mentioned in the past that the target knockdown level is about 80% for the 2001 trial. So right now you have almost set up the timing of the presentation. Does it mean you already reached the target level in the initial dose level?
The way we've approached this is we've said from the outset that we would share interim data from the studies of progressive. Remember that there's two phases to it, the ascending dose phase and then the expansion phase, where we would take what we think will be the optimal biological dose and study that more fully in a larger set of patients. The principle that we've applied for this first phase of the study is that we'll have meaningful results that are readily interpretable. We haven't tied that to a specific target for this particular data release. It's true that we set it to benchmark 80% and beyond. Our objective is to surpass 80% because we think the further one reduces the circulating TTR levels, more beneficial it's going to be for patients. And I think there's places we can look for data that seems to indicate that. So that is our ultimate objective. But the particular data that we share here is not necessarily triggered by any specific number.
Thank you so much.
Thank you. The next question comes from Mani Foroohar with SVB Leerink. Please go ahead.
Hi, good morning. This is Rick on the line for Mani. Thanks for taking our questions. So I actually have a follow-up on Maury's question on safety, and specifically, there are a few novel components being evaluated here for the first time in the clinic, and that's the LNP formulation, the transient expression of Cas9 and guide RNA in the liver, and then the actual edits being made to the genome. So I was hoping to just get your thoughts on if there is any sort of safety signal observed in the trial, what the ability is there to parse out which of those components may be contributing to the signal, and potential read-throughs for the rest of the in vivo platform.
Yeah, so we're talking in general how we think about safety, and the way we approach it is, there's the LNP itself and its administration, and then there's the long-term effects of that particular intervention, which we expect to be largely beneficial based on the expected TTR knockdowns that we've achieved in animals. LNPs as a class, you may remember, Rick, generally have a characteristic pattern of safety findings that when one gives sufficient quantities of material, you can trigger. All that we've worked on very, very carefully in our preclinical work to develop a therapeutic index. So the clinical exposures that we're doing in the human trial here is designed to balance the desired and expected TTR effects within the therapeutic index that does not trigger those particular LNP class effects. And, the phase 1 study is to test exactly that, those preclinical findings. And as we've said, we'll share some of the early results here mid this year. With respect to novel components, I guess the way I think about it is the LNP is largely precedented. Yes, there's a unique piece to it that is the proprietary lipid or cationic lipid. But we think we characterize it very, very well and know very well how it behaves based on preclinical work. And the rest of it is RNA, either guide or mRNA, and again, we can use really good preclinical models for that. With respect to the genomic characterization of the effects, That's been extensively addressed preclinically. I would say more than probably any other drug, as far as I'm aware. I would encourage you to attend the ASTCT meeting where we're going to go through a lot of how that work is done, so you get a really good sense of the completeness and the extent of that effort. So we can maybe revisit after we go through that data later this month.
Got it. Really appreciate all the detail there, and thanks again for taking the question.
Sure.
Thank you. Your next question comes from June Lee with Truist. Please go ahead.
Hi, thanks for taking our questions. You just set your bar at 80%, which is what I guess siRNAs and antisense oligos hover around that knockdown level. But as a genome editing tool that is constantly working, do you really need to hit similar knockdown as those antisense oligos or siRNAs to achieve similar clinical efficacy? Or could you envision a situation where you could get less knockdown but still get equivalent or better clinical effect? And could we get clinical data this year as well as some of the knockdown levels? And I have a follow-up question.
So it's a very important question you're asking, which is when we talk about these numbers of knockdown, what does it actually mean, right? And so the numbers are typically presented by some of the other modalities that I'm familiar with, at least, are typically portrayed as maximal effects. And what you're asking is essentially an area under the curve question, which is, well, excuse me, if you have a maximal effect at a particular number, call it 80%, what is the average effect over time? And one of the advantages of the approach that we're taking here is that the maximal effect is the effect because there's no pharmacokinetic variability that occurs over time. Our approach to this is we look at 80% as the benchmark. The goal is to surpass it, not just from a maximal effect, but from a sustained effect. And if you go back to some of the preclinical data that we presented, you'll see that when it comes to the animal models, that's exactly what we achieved. So our thesis is that reducing TTR to the lowest possible levels in the blood is going to lead to more clinical benefit, and that's exactly what we're setting out to achieve here. So that's how we think about it.
Okay, so we'll get clinical data along with the knockdown video?
So in the early phase of the study, remember it's a 3+3 design, there's 4 cohorts, so the extent of clinical data I think is going to be very modest here early on. What I would look to is primarily a safety characterization and primarily a TTR effect. There's descriptive clinical data, but the bulk of that information I would look to the second phase of the study.
Got it. And then one more question. For this in vivo genome editing for hematopoietic stem cells, what is the distribution of bone marrow tropic LNP in the liver versus bone marrow, and how does that play into the overall efficacy and durability of this approach for sickle cell disease? And does this program, take any priority in the overall portfolio strategy given the announcement between, CRISPR and Vertex, where they seem to be moving aggressively to commercialize it? Or does this not impact your overall strategy? Or do you have something in agreement with Novartis that kind of limits your ability to develop therapeutics? Thank you.
That's a big question with many subparts. I'll tell you how we think about it. Without going into all the specifics of, distribution between liver and bone marrow and various other compartments of the body, obviously, the objective is to get the right amount to the appropriate cells in the bone marrow. And it's very clear that LNPs as a class have a tendency to be picked up fairly avidly by the liver. So part of the delivery challenge is addressing the avidity of that clearance that takes place in the liver. We've made good headway with respect to that, and there's a variety of ways to do that, and our scientists are working on many of them. And it's premature at this point to talk about exactly how we're doing that. But as time unfolds here, I'm sure there'll be opportunities to talk more about it. Just broadly speaking about sickle cell and related disorders of the hematopoietic system, we're very excited by the progress that others have made that show, I think, pretty clearly that one can edit hematopoietic stem cells and treat sickle cell disease pretty effectively. And that's great news for that set of patients who we all know have long suffered with very, very, inadequate sorts of therapeutic treatments. The challenge, however, is that to get to those benefits, one needs to be subjected to a bone marrow transplant, which brings with it significant morbidity and even in some cases mortality. And so our view is that the final end game here is avoiding that bone marrow transplant. We know how to edit. It's just getting rid of the bone marrow transplantation. So our belief is that solving that with an in vivo delivery system, that is what will address the fundamental problem here. So other relationships and other approaches that people take, we admire their work and encourage them to proceed. Our approach is to have something that we think will have the broadest reach and the best solution for the greatest number of patients. And that is what we're working on, and that's what the Gates Foundation has been helping us to do.
Thank you. I'm looking forward to the data.
Thank you.
Thank you. The next question comes from Stephen Steedhouse with Raymond James. Please go ahead.
Thank you. Good morning. I'm surprised to see you guiding to submitting an IND or IND equivalent with your follow-on products. It just seems to imply that either you haven't, decided which geography you plan to proceed or that you don't want to say. And I guess I just don't understand why the ambiguity or intrigue is even necessary unless, you really don't know and kind of ex-U.S. trial as a backup plan at this point. That's basically how it reads to me. So my question is, I was just hoping you could be clear, do you actually have plans to file a U.S. IND near term for HAE or AML, or can you say already right now those will be ex-U.S. trials? And if you aren't certain about a U.S. IND still, can you say, have you had any pre-IND meetings recently, and can you share insights from those interactions? Thank you.
Well, we're not going to change what we've said, but I thank you for the question. We'll be in a position to give you more clarity as we proceed here. We shared exactly the same guidance with respect to Intellia 2001. We are very, very engaged in the regulatory interactions, and we've certainly been discussing things with the FDA as well as other regulators. And we're putting ourselves in a position where we can have the broadest based program that gets the most clinical information most efficiently. So I'm sorry I'm not going to be able to address specifically your question, but as time unfolds here, we'll share more information.
Appreciate it. Thank you.
Mm-hmm.
Thank you. The next question comes from Ian Nzu with Wells Fargo Securities. Please go ahead.
Hi, thanks for taking my questions. A few questions on 2001. First, in terms of the place, the venue of the medical, the specific medical meeting, is it reasonable to assume it is a PNS meeting in June? And also, could you characterize a little more what you mean by interpretable data? Does that mean data within a certain variability that you could, make a judgment of the result, or could it mean your ability to project some kind of a dose response to predict what might happen with additional dosing? So that any color around that will be very helpful. Thank you.
Sure, thank you. With respect to the particular meeting, we're not sharing that information just yet. However, we won't be surprising people as we get closer to that point in time. We will share in a press release when and where. People, I think, will have plenty of information in advance to be prepared to attend the meeting or interact with it to get the information. With respect to interpretable data, that's a principle that we've applied, which really speaks to exactly what you said. With small numbers of patients in an ascending dose study, one always pays attention to variability if it's there, and one wants to be able to look at those data, see if there's an effect, and how make some assessment of what it's likely to mean for not only Intellia 2001 and how it will fit into the pharmacopoeia, but also our platform generally. So those are the principles that we've applied, and I think when we're in a position to share the data, you'll see that we've addressed them.
Thank you. A quick follow-up. In your EU orphan drug designation application, did the committee ask for clinical data? I think because obviously there are chronic therapies, so in some precedents when when there is a standard of care, the committee might ask for data when determining orphan drug status. Thank you.
Yeah, I think the committee, as it makes its determination, asks whether or not there's remaining unmet need, and they concur with the broad-based source of information we get, which includes KOLs, patients, and treating healthcare personnel. So it's less about clinical information; it's about the status of the current treatment state of the art.
Got it. Thank you.
Mm-hmm.
Thank you. The next question comes from Sylvan Kirkin with JMP Securities. Please go ahead.
Thank you. Congrats on all the progress, and thank you for taking my question. First, also, I wanted to ask about a comment from Laura. Could you just please confirm that you mentioned that you may want to start Intellia 2002 at a higher dose compared to Intellia 2001? And if that is the case, can we read across from that information to Intellia 2001 saying that the first lowest dose is probably safe or that it may have been too low? Thank you. And then I have a follow-up.
I'll stand in for Laura here, I guess, just to keep it efficient. But, it all goes back to the fundamental premise of modularity. So whether it's on the research side, whether it's on the preclinical side or on the clinical side, what we learn for an LNP and its cargo broadly applies. And so as we collect information from any of those different domains, what we found is that we can apply it to subsequent incarnations of the product and various either regulatory interactions or even clinical interactions. So the information that we have is, I'm not going to characterize it other than that it's able to give us some bearing on how we approach 2002, and it may have some utility there.
Thank you so much. And my follow-up question is, could you have possible redosing in the expansion part of the trial for patients that don't reach the target knockdown levels for some reason, or is that something you would explore in a later trial?
Yeah, broadly based in terms of how to think about the trial, it's formally a single ascending dose study in a single application. There are provisions that we're making in the course of the program, and perhaps in this study, this is work that we're addressing where suboptimal doses, if they occur, those patients may have subsequent recourse to a more active dose. But as that gets clarified, we'll be in a position to talk more about it.
Okay, thank you. And maybe one quick last question, if I may. Just on big picture, are there any pitfalls that you can point to if we would compare the Intellia 2001 data set to tafamidis or patisiran in terms of time to peak or steady state knockdown level or patient populations? Anything you can point us to for this readout to tell us watch out for this or just make it follow?
I'm not sure I got the gist of your question. You're asking about tafamidis and knockdown effects? versus Intellia 21. Is that what you asked me?
Yeah, when we get the CR reduction from Intellia 2001, what are some of the straightforward comparisons we can do to the other agents, and what are some of the watch out for in terms of stable knockdown levels, etc.
Yeah, I mean, with respect to this particular study, there are exclusions with respect to what other people can take or will have taken ever before coming into the trial. So in terms of measuring any of that in the course of that study directly, that won't be a part of it. With respect to the behavior of TGR and its decline, I think there'll be a fair amount of information that we would expect to interpret. And one can look at the siRNA material and, which is the relevant knockdown comparator, I think. TTR levels are not knocked down by tafamidis, so it's a different kind of calculus that one might make. But I think one would expect to have a pretty good set of data to make some broad-based comparisons based on what we're expecting to share.
Great, thank you so much for taking my question. Congrats on all the progress.
Sure.
Thank you. The next question comes from Jay Olson with OPL. Please go ahead.
Oh, hey, thanks for taking the question. For the base editor system that you recently presented, will that base editor be used in both in vivo and ex vivo programs, and how do you plan to integrate that tool into your overall platform?
Yeah, thanks for the question. We're very excited about what particular sorts of applications base editors may be applied to. We see their greatest utility in the ex vivo setting. It's not currently a part of the programs we've been talking about. If you saw the presentation we gave at Cold Spring Harbor, one of the things that we're very mindful of is the state of the art in terms of looking for stochastic off-target effects in the in vivo setting, and that's where we think there's additional work to be done from the field broadly. So in the nearest term, we think that the ex vivo setting is probably the best place to use the base editor, but I'm sure work will continue and that may change over time.
Great, thank you. And then maybe as one follow-on question, for your upcoming presentation at ASGCT, what kind of preclinical data should we be looking for, and what are the gating factors to moving that program on to the next steps?
Well, at ASGCT, remember there's two presentations that we're making. One is a very detailed analysis of the off-target approach, which speaks broadly to what we do, so it doesn't relate necessarily to any particular program. The other presentation will be on extended information on the alpha-1 antitrypsin program. We're not talking yet about its status with respect to the pipeline and its candidacy, et cetera. We will have a third presentation where our CSO will also be speaking broadly about gene editing and its clinical utility, so there'll be some other insights, but we won't be talking about particular development candidates and changing their status there.
Great, thanks for taking the question.
Sure.
Thank you. The next question comes from Joe Allen with Baird. Please go ahead.
Hi, thank you. It's Jack Allen here. Thanks so much for taking the question. We wanted to touch briefly on Intellia 2002, and we were wondering if you could talk a bit about your expectations for the trial as you move it towards the clinic. It's our understanding that there are a number of therapies already approved